Welcome back to my channel. This video is going to be another educational video on teaching about furcations. Now, in our general dentistry practice, the most common things or most common cases that are misdiagnosed are periodontal cases. And of all the periodontal cases, the things that are not usually diagnosed is furcation. Have you ever encountered a case in which a patient comes to you, tells you, I have a lot of pain in my posterior tooth, in my lower back tooth, and it's been hurting from days, it's uncomfortable, it has no bearing when I'm eating or not, it's not related to hot and cold, and you are there wondering what exactly has happened. You look at the radiograph maybe has the tooth in question, has a occlusal amalgam or a composite restoration, but other than that, you don't see any decay. You do the cold test, everything is normal, and there you are wondering what exactly has happened. Now, sometimes people even diagnose those cases as cracked tooth, although it could be just a simple occlusal restoration, which is not even deep. But then, due to the lack of coming to a diagnosis, either they will be diagnosed as a cracked tooth or they will be referred to a specialist for further diagnosis. These are the kind of cases where you have to understand and go a little bit deeper, dig deeper in your knowledge base, look in your books, and see what exactly is happening. So, what I'm going to do in this video is I'm going to discuss the difference between pulpal pain, periodontal pain. Pain is really important. I recently posted a thing on LinkedIn, and the case was about how you can make your differential diagnosis just by listening to the patient. I will be posting a link in my description on that LinkedIn post. You can go back and look at that post and see what the case was about. It was a very interesting case where the patient was having a lot of pain in the tooth, and they were told by the other dentist that they have a cracked tooth syndrome or a cracked tooth. And when I was seeing the patient, due to my periodontal background, immediately from the symptoms, I could make out that this was not related to cracked tooth, it was more of a periodontal pain. So these kind of cases tell you that pain, understanding pain is really important. It's not theoretically, we are taught about the difference between pulpal pain, periodontal pain, how does a cracked tooth pain is like, or how is a TMD pain feels like. It's really important. If you want to enhance your practice, if you want to, garner the confidence of your patients, I think it's really important to have that history. And sometimes we are missing out on taking that perfect history, which can help us in diagnosing the case, right? So, what I'm going to do is I'm going to be talking about pain, and then I'll go to furcations. Again, this is not going to be an academic, theoretical chapter reading kind of a presentation. It's very much a clinical presentation, something meant for you to understand how to diagnose periodontal problems. And in this video, the periodontal problem we are discussing is furcations. If you like this video, please like, share, and subscribe with anyone you think would benefit. Okay, let's go and get started. So, furcation. From the first picture, you can make out furcations. You've all read about it. You've read about root trunk, root cones, and divergence. So, we all are aware about furcations, and I'm assuming that you know exactly what it looks like. I'm going to move forward here with pulpal and periodontal pain that I mentioned. Now, when your patient tells you, I have a very bad pain, it's so severe, I've not been able to sleep. Now, directly we cannot jump to pulpal pain. I know normally when we are taught in schools or when you see a lot of patients, when they say, I'm not able to sleep because of the sleeping relationship, that okay, when you sleep, the posture changes. We ultimately, directly we'll just jump to pulpal pain. But well, a little bit deeper, ask the patient, what kind of a pain is it? Is it a very dull pain? Because even a periodontal pain, which is like gnawing and throbbing and dull and aching, even that would not let you sleep. So It's not always that the patient tells you I'm not able to sleep at night is going to be a pulpal pain. It could be a periodontal pain, a dull, throbbing, aching pain that is persistent throughout the day. Okay, pulpal pain, definitely the quality of the pain varies depending upon the condition of the tooth, like that is mentioned here. It could be based on if the tooth is vital or the tooth is non-vital. So if the tooth is undergoing necrosis, then we know the pain quality differs a little bit. If the tooth is vital, then it's mostly like a sharp shooting pain, or it's even going towards being non-vital, sharp shooting pain. Usually pulpal pain we associate with sharp shooting pain, but it also is related to hot or cold. Periodontal pain as such would not have any bearing with hot or cold. It's a dull, throbbing pain which could be felt radiating throughout, and it's not has an does not have any relationship that you ate something or you are feeling cold to you're feeling hot. It's in response to any hot or cold stimulus. Okay, second thing, so once you've asked, okay, what kind of a pain it is it throbbing, is it sharp shooting pain, you are going to move towards clinically, you're going to look at the teeth. Okay, now plaque and calculus. Definitely, whenever there is a periodontal pain, mostly you will see a lot of plaque, you will see maybe calculus, but mostly plaque. But plaque and calculus are not really related with the pulpal pain. Now, why do I say mostly? Because it can happen that the patient who comes to you is having a very clean mouth. They're really brushing very well. So then again, do not say, oh no, I do not see any plaque. So it cannot be periodontal pain because plaque is the primary cause. Yes, plaque is the primary cause of the periodontal pain, but there could be other reasons which are aggravating it. It could be minor mild collection of plaque also that could be aggravated by other factors contributing to the problem and causing periodontal pain. So just do not rule out periodontal pain just because your patient does not have enough accumulation of plaque. Okay. Third thing that is important is localization. Now, we all know about the nerve fibers. Again, I'm not going to go deeper into understanding the nerve pathway here, but the pulpal pain is poorly localized. What do you mean by poorly localized? If you ask the patient, can you pinpoint which tooth, the patient will never be able to pinpoint. They'll say maybe this one, but this one. And if you try to do the percussion test, they will usually say, yeah, this also hurts and this also hurts. Oh, yeah, this hurts a little bit more, right? So the pulpal pain is very poorly localized, whereas a periodontal pain is precisely localized. Precisely localized, yes, because of your receptors and also because of the presence of a pocket in that region, or it's very easy to locate a periodontal pain. They will definitely say, yes, this tooth is hurting. When I nick here or when I put my finger here, it makes me feel much better. That is the periodontal pain. Okay. So this is really important. Again, this could be a part of your history. Is it localized? Can you pinpoint where is it hurting? And can you tell me what kind of a pain it is? And what do you do when the pain is happening? Does anything help to relieve the pain? Okay. And after that, again, in your clinical diagnosis, very important thing that you have to check is a periodontal pocket. Whenever there is a periodontal pain, there will be a periodontal pocket. Okay, so you have to check all around the tooth. Just don't do it. I know a couple of people who are always like they just go around the tooth like mesial, distal, that's it, done. No, you have to go all around the tooth because furcation involvements. Again, I'm assuming you know it. Furcation, like in a mandibular molar, will be your buccal and the lingual furcation involvement. So you will be able to diagnose if you have actually moving the probe 360 degrees around the tooth, and then you'll be able to have a dip in one region or the two regions. You will be able to actually have periodontal pocket like 5 millimeter or 6 millimeter. So do understand that a periodontal pocket will always be accompanying whenever there is a periodontal problem. So whenever there is a furcation, you will see some kind of a periodontal pocket in that region. It could be 5 millimeter, it could be 6 millimeter, it could be anywhere. It's just not necessarily going to be in the mesial or in the distal. Okay, so I hope you've understood. First thing that you have to start with when a patient comes to you is pain. Understand what kind of a pain it is, what bothers them the most, what helps them relieve it the most, what kind of factors are associated with it in your clinical diagnosis. Okay, so now once we've understood pulpal and periodontal pain, a little bit about furcations now. So furcation involvement, like you can see in the picture, it's the invasion of the bifurcation and the trifurcation of multi-rooted tooth. I think that's pretty clear to any of us. It can be visible clinically or covered by the wall of the pocket. And that's also there. Either you have recession happening, and you can definitely see there is a furcation involvement, or like you can see in this picture, or you can have it covered by the soft tissue and you will not be able to see that there is a furcation involvement happening. So furcation happens how? Like when I said that a periodontal pocket will always be accompanying even if there's a furcation. Why? Because furcation is also just a rootward extension of inflammation coming from your pocket. It's just another inflammation that is spreading from the pocket towards the furcation region. So I think it kind of makes it better understandable in here that a pocket is always going to accompany if there is a furcation. Okay, let's go to causes. Now, why causes are important? I think causes is not only important for you to understand why there is a furcation, but sometimes patients also ask you, what is this exactly? I've been in practice for so long, and you always meet such patients who will ask you is what. So, to not fumble and to be very sure, you should also know about all the causes. And like normally for every periodontal problem I mentioned, plaque. Plaque is the primary cause. Patient might be brushing well now, but maybe they were not brushing before, or due to whatever reason, they were not able to maintain hygiene in that particular area. So, plaque is always going to be the primary cause of furcation involvement. Second, trauma from occlusion. Now, what is trauma from occlusion? I think there's a lot of controversy around understanding about trauma from occlusion. When patients have a very heavy occlusion bite, due to whatever reason, it could be their physiologically, their teeth are in a very heavy occlusion. So that constant biting on that tooth, constant heavy forces, the forces, and then you have plaque in that area could trauma from occlusion. If you go to the chapter trauma from occlusion, if you have no idea, leave me a message. I can help you a little bit more in understanding trauma from occlusion. Trauma from occlusion itself does not cause anything. Trauma from occlusion in the presence of plaque definitely causes what we are saying is furcation involvement or other things. So trauma from occlusion is why this is controversial, because again trauma from occlusion itself doesn't cause anything. Trauma from occlusion in the presence of plaque, it has been suggested that furcation areas are more sensitive to injury because of the constant biting that causes forces on the bone and on the tooth, makes your furcation involvement more easier as compared to if the bite was normal and there was very little plaque also. Okay, cemento enamel projections. You've all read about cemento enamel projections. It's taught in every perio book, in every perio subject. You'll be taught about cemento enamel projections. So, cemento enamel projections definitely clinically, if I'm coming to you or a patient is coming to you, you will not be able to see, oh, there is cemento enamel projection. But cemento enamel projections is something when you are doing a surgery, you will be able to see cemento enamel projections, which are again harbor of the plaque. They harbor plaque, and that causes again extension of inflammation and causes furcation involvement. Okay, so that's considered one of the most common causes again. Fourth cause, which is very important, is presence of accessory pulp canals. Okay, 36% of maxillary first molars 12% of max the second molars, 32% of mandibular first molars, and 24% of mandibular second molars. So you always have accessory pulp canals, and every time and there is some kind of infection that is happening endodontically, it can spread through your accessory pulp canals and into the furcation and cause furcation involvement. And this is what you study when we talk about endoperio involvements, endoperio lesions. As you can see in the picture here, you can always have an involvement from your canals, from the pulp into the furcation area. So endoperio lesions are very important. Pulpal infection drains to accessory canals, especially in the furcation, leading to furcation involvement through the loss of clinical attachment and alveolar bone, right? So again, like I'm saying, that your accessory pulp canals can cause the spreading of inflammation. That means what happens is sometimes, which most commonly is even you will see dentists that they will say if there is a patient is having a small amalgam lesion or or a composite restoration, and the patient is complaining of a lot of pain, they would say, and if you even if you see something happening in the furcation area in the bone, you would say, oh, let's go through the root canal. Why? Because of the same reason, that there are accessory pulp canals through which probably the infection is spreading, has gone to your furcation region and caused the loss of attachment and bone, causing furcations. Now, how will this usually present? Whenever there is an endoperio lesion, how will this be presenting? This would present as a localized, deep periodontal probing depth. So you will have a localized periodontal deep, probing depth. So it's not like, maybe, like I said, you always have to probe, because it's not necessary that the probing would be present in one region, throughout the tooth. It would be present in one region. Especially when there is an endoperio lesion, you would be having a localized deep probing periodontal depth, and that extends to the apex of the tooth. And what could be actually happening is your mesial and distally probings are fine. So if you are just probing on the mesial and the distal, probings are completely fine, and you would be like, no, there is no periodontal problem happening because the probings are fine. The problem is that you did not probe completely, because in the buccal or the lingual, because of the presence of the accessory pulp canals, the furcation involvement would happen, and you missed the furcation or the probing depths in the buccal or the lingual region. That's where you should have probed. Okay, so it's really important in such scenarios where you suspect an endoperio lesion to probe all around the tooth. Okay, now that we have understood the causes of furcation involvement, I'm going to just run by explaining the classification. You've understood that there is furcation involvement happening. Now, as a general dentist, no one is expecting that you have to treat the patient right there and then. And we will be talking about the treatments, but why do you have to diagnose? Why do you have to classify also? I think it's really important to classify, because you will be referring that patient to the periodontist, or maybe like in grade 1, you can definitely yourself go through a SRP. So if you do not even know what the grade is, how will you even come to a treatment or explain your patient about the treatment? So important is to understand the different grades. You have grade 1. This is the simplest classification. There are lots of furcation involvement classifications, but to keep it easier and simpler for this presentation, and I think it will be really easier also when you are practicing in the clinic, to have one single classification to understand what my treatment could be if I'm referring out or if I'm working on them. Grade 1 is incipient bone loss. Name suggests it's just started. Grade 2 is partial bone loss. Grade 3, you have a bone loss, and you can even, there's a through and through opening of the furcation. Like your probe will go completely through, and I have pictures after this and I can show you what exactly I mean. Grade 3 is total bone loss. Grade 4 is also total bone loss, but there is gingival recession, like the gums have receded, and now you can actually, when you probe through the neighbor's probe, you can even see that there is furcation involvement. So let's see here. So class 1 or grade 1, you can see this is simply incipient bone loss. Even in the radiograph, you cannot really make out that there is anything happening here, right? Okay. Let me have a pointer here and I can actually show you nicely. So grade 1, if you can see, this is grade 1. Now you cannot really make out completely. You can see a tiny radiolucency, but it's not something that is appreciable. That is called as grade 1. Let's go to grade 2. Now, grade 2, if you can see here, your neighbor probe, it goes inside but not all the way through. However, in a radiograph, you will be able to appreciate radiolucency happening. Grade 3 is where it goes through and through. Again, you can very nicely see the radiolucency here in the furcation, but it doesn't, it's still covered by the soft tissue. So the soft tissue is still covering it, so it won't come out from the other side. And see, this is a very clear picture. See, your probe is going all the way to the other side, right? Radiolucency again is common. It's going all the way to the other side. Why? If you see, the bone loss has happened. The bone loss has happened and the gums have gone down, exposing the furcation. In this picture, you still do not have enough bone loss happening on the mesial and the distal. That means the gums are still covering the tissue, the furcation. So when your probe goes in, even if it's like through and through, you will not be able to see completely because the soft tissue is covering. So the only difference between grade 3 and grade 4 is you have the soft tissue covering. Grade 1, you will not be able to make out, but when you probe, the probe is one of the important criteria in grade 1. You will be able to probe. You will get a deeper probing depth for sure. Okay, and in grade 2, your neighbor's probe will definitely go inside. Now you can have a colored neighbor probe. This is one with the marking. So 3 to 6, 6 to 9, very easily you can see how much of my probe went in. And there's another classification that tells you, classifies furcations based on how many millimeters it went in. But otherwise, you can just have a clinical idea of, okay, my probe is definitely going in. This is the neighbor's probe and there is furcation involvement, right? Okay. Now, once you've understood furcations, how you've moved from, I've understood this is the patient presenting with, okay, I've checked for furcations, I've checked for deeper probing depths, I've understood. Let's correlate everything that we learned so far. So I told you that we are probing with the neighbor's probe, right? Now, radiographically, furcations are identified, like I said, as triangular radiolucency in the bifurcation area. So, see this. Now, these cases are mostly grade 2s, or sometimes even grade 2 doesn't present with this much radiolucency. Sometimes if you see here, even there is a grade furcation involvement happening here, which is very mild radiolucency in the furcation area. But if you see a radiolucency in the furcation area, there is an India, and then you probe, you will know that there is furcation involvement. So these are triangular. Don't forget, these are triangular radiolucencies in the bifurcation or the trifurcation area. And look at this clinical picture. My neighbor's probe has gone all inside. And clinically, do you see this much? See this, how much of bleeding is happening here, how much inflammation is happening here. It is a very good picture of a clinical picture of furcation involvement, right? Now, another radiographic criteria. The slightest radiographic change in furcation area should be investigated clinically, especially if there is bone loss on adjacent roots. Like I said before, for grade 2 furcations, you will not be surely able to see the radiolucency that we talked about. But if you see here, there is tiny radiolucency happening, this one, which is very tiny, and you can see bone loss. So how can you be sure? How can you be sure? So if this patient comes to me and I see bone loss happening on the mesial and the distal, very tiny but happening, and then I'll see in the furcation area a little bit radiolucency, I'm going to definitely probe this patient 360-degree everywhere, mesial, distal, buccal, lingual, and check if there's any kind of a furcation happening. Early furcation involvement is suggested by any kind of fuzziness. Okay. Second, diminished radiodensity in the furcation area in which outlines of bony trabeculae are visible. Now, see this here, furcation involvement you are having of mandibular first, mandibular second molar, and what is happening here? You can see thickening of the periodontal space, how wide this area has become. You can see this, how wide the furcation area is becoming. Similar here, I'm not going to color it so that you can make out. So thickening of the periodontal space in the furcation area. Again, if you go to the third molar, you can still see little bit radiolucency here also, but probably here the external oblique line is kind of obstructing that picture clearly here. So when you go through radiographs, radiograph interpretations can help you diagnose a lot of cases. So again here, thickening of the periodontal space, definitely radiolucency is here, and again in the furcation area in the third molar you can see radiolucency. Whenever there is marked bone loss in relation to a single molar root, it may be assumed furcation is also involved. Now you see here, again, this is the bone loss. So first molar, right? And here you can see how much bone loss is happening here. Usually in such cases also do look for furcation involvement. Whenever there is a marked bone loss, definitely there is something happening. Definitely there could be a suffocation involvement. It could be not, but it's always good to check and look for those signs. Now, I've told you exactly how to look for furcations. It's not really difficult. It's all about radiographic interpretations. You just have to go and look at a radiograph when a patient comes to you with a complaint of pain. Talk to them, figure out what kind of a pain they're talking about, right? Second, go and check clinically, do all the nice probings, check for probing depths clearly, have your neighbors probe with you, check for the furcations, and then also look at the radiograph. Radiographs can tell you a lot, especially about furcation, especially if you have a grade 2 to grade 4 furcation. You have to look for bone loss. You can easily diagnose furcations in such cases. Okay, now once we've established this is furcation, if you are a general dentistry practice, you do not have a periodontist there right now, and you have to refer, what are the treatments that you can do for the patient, and then where do you refer? Grade 1 is usually non-surgical that you have to do. So when there is involvement of a grade 1 or a class 1, you do not have to do anything. All you can do is SRP for such patients. Okay, initially. So what you'll do if there's grade 1, you can definitely, even if there's grade 2, you can start with SRP, deep cleaning for that localized area, do a thorough SRP and have the patient come back to you. For grade 2 to grade 4, if it's I said for grade 2 you do SRP, but these patients should definitely be sent to the periodontist also for further evaluation. Grade 3, grade 4 definitely should be sent to the periodontist for further evaluation, because the treatments for grade 3 and grade 4s are surgical. They will be doing GTR or osteoplasty or if needed hemisection. We don't do hemisection, but this is something that a periodontist would be figuring out. Okay, so in what you can do as a general dentist is diagnose the pain, diagnose, understand the radiographs completely. If you diagnose that is furcation involvement, if it's grade 1 to grade 2, you can go ahead, definitely do SRP and then refer them to the periodontist just for evaluation. Grade 3, grade 4, which are surgical treatments for sure, are going to the periodontist. I hope with this presentation you've understood a very important case, a very important factor that can lead to so much pain and is not most commonly misdiagnosed, furcations. If you have any doubts, leave your comments in the comment section. I'll be happy to help you out, tell you more, or maybe provide you more sources. And again, like my video and subscribe for more educational videos. I'll see you again. Bye.